broadcasting from Miami, Florida. Tonight we have the honor of having George Mendes. He's a neurosurgeon from originally from Brazil. Well, now he's in France, and he's going to tell you about that. He was introduced to us by Julio, the brains behind this operation, and George is going to tell you what he's going to talk about. But first, we'll go around and introduce ourselves briefly, the panel. Okay, Dustin.
Hey guys, my name is Dustin Kinch. I'm a software developer from South Florida with a focus in mobile health technology.
Welcome, Dustin. Diego?
Yep, thank you, John. My name is Diego Menchaca. I'm an entrepreneur located in Santiago, Chile, and I have an app called TeamScope. You can find more info on teamscope.co.
Okay, Simon. Welcome, Diego.
Hello, my name is Simon Downs. I'm a developmental psychologist working out of Tokyo, Japan. I'm also part of a medical device team for a bone-conducted hearing aid, and I'm also a medical student.
You're welcome, Simon. Okay, I'll turn it over to Julio because he knows George pretty well. So, good evening, Julio.
Hi, good night. My name is Julio. I'm from Neurosurgery blog, and it's a pleasure to George is here. George is my friend. He's from Brazil. We did the same residence training in Brazil. He was my senior resident, and he loved to study about the neurosurgery vascular. So today we will have a good presentation, for sure.
Very good, Julio. Okay, George, welcome, and could you just kind of go into your background a little bit, and before you launch into your presentation? Thank you. Thank you.
Yeah. First of all, it's a pleasure to be here. Thanks for having me there. And yes, I'm a Brazilian neurosurgeon. Right now, located here in France, in Limoges, is a city of porcelain in the center of the country. And I got my training in Belo Horizonte, which is the capital of Minas Gerais state in Brazil, under the leadership of Atos de Souza. And then afterwards I moved to the States, and then I got some training and spent a good time at Brasil Neurological Institute, doing basically a school-based surgery and vascular surgery, mostly linked to the labs and research. And then afterwards, I moved here to France, Limoges University, where I'm finishing actually my clinical fellowship. I'm actually a senior fellow here in Limoges. And then after 9 years training, I will complete my full training, which is vascular open surgery and endovascular. And then this is a kind of a field where in which I'm going to work back home in Brazil. Hey John, I cannot hear you.
Yeah, I can't hear me either, but I got a tech.
Yeah, here I am talking, and
okay, go ahead.
And it's muted.
Yeah.
So is that what kind of a fellowship is that exactly?
Yeah, actually, you know, it's kind of endovascular. So you have vascular pathologies in the brain, and you can treat by using surgery, open surgery. It means that you make a craniotomy and then an open surgery, and then you arrive in the vessel. And then, for instance, the most common disease is the cerebral aneurysm. So you go there, and then you put a clip, and then you treat the patient by using, you know, pretty nice technique, actually more than 30 years outcome, and is the traditional methods. Or you can go and treat the same diseases by using endovascular, by the growing, using a combination with catheters and microcatheters, and then you go around and arrive inside the aneurysm, which is a kind of bubble inside the vessel, and then you occlude it by using classically coils, but you also nowadays can use different techniques, and it's kind of a field which is advancing a lot by using technology and understanding of flow. So you have different means to treat the same disease, and my goal, and the goal, which is a goal for a couple of pretty frequent background in the States nowadays, is kind of it's the ability to treat by using both ways. So you decide which way is the best to your patient. So you tailor the method for specific patients, and then you can provide better outcomes, avoiding complications. So it's that's the goal by training in both techniques.
This is probably kind of a naive question, but I'm a non-neurosurgeon. Do you go in? You go through the carotid, or you go in through the groin?
Actually, you enter by the groin, and then you use a combination. So we use kind of guiding catheters and then the microcatheters. So the guiding catheter is usually placed in the carotid artery, and then you go inside the brain vessels with the microcatheters, and then you go inside the aneurysm, the lesions. I'm talking about aneurysm, but we treat everything, every single vascular disease which are linked to the vessels itself, because you have kind of a sort of different vascular disease that we cannot reach it by using endovascular, which is cavernomas and other lesions. So mostly treated by surgery, open surgery and microsurgery. So nowadays you have two options to treat the most frequent ways, which are open, that's what I mentioned, is pre-mechanically, but it's well standardized and well determined regarding outcomes. And then you have this kind of minimally invasive techniques, which were mostly developed here in this country, in France. Pioneers were here, and they have much research in this field, and developing new devices to treat the difficult situations. So it's fascinating to me to stay here and work with these people.
And that's why you went to France, because they have pretty advanced neurovascular studies.
Endovascular, yes, because it's a clear difference than the U.S. In the U.S., you guys have a really fancy neurosurgery, and open surgeries were developed in the U.S. and they are pretty advanced there. You have either very nice endovascular departments there. France is actually the country in which they developed the technique. So the pioneers were here. So that's the reason that I came to France. It's mostly to work with pioneers, likewise nowadays. So I work in the department which the chairman of the department was the pioneer to embolizing cerebrovascular arteriovenous malformations and this kind of new treatment strategies that they develop. So it's a kind of pretty different field here in France, because the field is mostly done by interventional neuroradiologists, and the US mostly done by neurosurgeons, likewise myself. But that's what I'm searching here, and I'm working here, is kind of understanding better imaging and flow and this kind of different approach for the lesions, that they have different philosophy here. So it's that's the reason that I came here. It's to kind of get more and more new information and to work with patients here.
You know, I'm sure Julio probably will ask the same question, but maybe the other guys have the same thing in their mind. Now, a neurointerventional radiologist, do they do more in the United States than they do in France? Is that what you're saying? That in France, the neurosurgeon does more of the...
No, it's the opposite. It's the opposite.
So,
It's the
okay.
opposite. It's the opposite.
So he does less.
Yeah.
Okay.
Because actually here, it's my opinion. It's my opinion. It's actually here in France. You know, you have specific interventional neuroradiology departments which are separated than the neurosurgical department. So
Okay.
that's the reason. And then, see what I'm saying? They develop the technique, and then they take a lot of cases by themselves. And it's a different field. In the US, so that's my experience when I was there, it's mostly done by neurosurgeons, which are very good either, but it's a different philosophy. It's just philosophy. The second thing is that devices, they take some time to be approved in the US, new devices. So here in Europe, in general sense, they can use mostly earlier than US new devices to treat this kind of lesions. And the interventional technique is mostly linked to devices because of, you know, you go there and then you treat there by using this kind of knowledge about, you know, flow and new technology.
Okay. Do you guys have any questions, Simon or Diego or Dustin?
Yes, I have some questions.
Okay.
George, you practice neurosurgery in Brazil, a research fellow at USA and France. In your opinion, what do you learn in each place? What the different? What? Because for me, your experience is very interesting. Because spend 2 years in the United States, 1 year and a half in France, and 5 years in Brazil. Can you talk a little bit about
that's actually a pretty good question, Julio. Yeah, definitely. My background is mostly, most of my time, I have 7 years neurosurgery background. So the thing is, neurosurgery to treat vascular diseases, as mentioned, is the traditional method, and is the, you know, the robust method to treat the diseases. But the thing of endovascular point of view is that they are developing a new field. So my experience in Brazil, by working with D'Souza there, and afterwards at Barrow, which is a, you know, world-renowned institution for vascular diseases, which has this chairman, Dr. Spetzler, is that neurosurgeons are able to treat every single vascular disease. But the thing is, you have nowadays, in my generation, these new options to treat patients. And as you know, you have to be cutting edge. So that's my point of view. And then, you know, to have both training is not that much easy. It's not that much easy because it takes you a long time. So what I searched there and I learned there in Brazil was, you know, really the technical point of view in neurosurgery. And then in the US, I improved a lot, you know, knowledge and all of these points. And nowadays, I'm kind of learning and advancing new technique and new points. My final goal is to provide, you know, to the patient treatment options and to decide with the patient which treatment is going to be the best one for that disease. So if I have a complex aneurysm for surgery, sometimes it's an easy aneurysm, for endovascular. So this kind of approach is, as I mentioned before, it's long time working, because you have to do dual training and work many years. But afterwards, in my opinion, you can have a good view on the disease, and you can offer to your patients and your departments, treatment options, because of you don't have the best treatment option. You have an option for each person, each disease, that you can do better. So that's my point of view nowadays.
I don't know if I understand you. Maybe you might have answered this, but I didn't catch it. But a general neurosurgeon, would he normally tackle an aneurysm or a complex aneurysm, or would he always refer it? Nowadays.
Nowadays, it depends on the country, it depends on the training, and see what I'm saying. So most of the neurosurgeons, they are able to treat aneurysms,
okay,
of course, but there are a couple of really complex aneurysms that must be treated by experts.
Okay.
And these experts, they got experience along the time. The difference nowadays is that these complex aneurysms, they can be sometimes easily treated by endovascular. See what I'm saying?
Yeah.
And then you provide, kind of easy treatment by using different techniques.
Right.
Regarding that specific person. So it's difficult to say, because it's kind of diseases, aneurysm or AVMs, they are mostly done by a vascular neurosurgeon, but a neurosurgeon, a regular neurosurgeon, he can do it, of course, because it's part of the training.
Right.
Nowadays, the recommendation is, you have multiple recommendations from different organs, but you have to dedicate yourself for the disease. It's not the same patient as a tumor patient or a spine patient in a general surgery. So mostly should be done for someone who has practice in that field or experience in that field. So that's the reason. When you do dual training, that's what I mentioned before. You do dual training to provide the best treatment to your patients, and regarding, of course, your experience and your skills for that aneurysm. See what I'm saying? It's not the same thing when I do, I'll mention here, it's, for instance, a difficult basilar tip aneurysm, or, a deep aneurysm, when I do endovascular, when I do surgery. It's not exactly the same technique. So by doing both, you can provide treatment options and improve your outcomes. That's my point.
Well, George, if you decide to do an endovascular approach to an aneurysm, what would you say the percentages of a successful outcome are? Or do you ever, I know in certain types of surgery, you try the least invasive thing first, and then if it doesn't work, then you open up the skull. What percentage is successful? Generally, is there a round figure?
Yeah, I would say that in a general sense, more than 80%. It depends on departments. For instance, the department where I work nowadays, it's 100%. So wow. we just don't have surgeries. But the thing is, as I mentioned before, it depends on the background of the department and the expertise of the chairman of the department. If you go barrel, it's completely different. If you go another institution, it's different. See what I'm saying? Or in Brazil, like we had different, because you have you know, kind of very expert surgeons, and they can manage, they can handle everything. So that's not exactly my reality, because of I'm kind of new generation. So this new generation, we are pretty linked to this kind of new technologies, and we are mostly working with you know, outcomes nowadays. So for us, it's a bit different than it used to be, for instance, 20 years ago or 15 years ago.
Mm-hmm. So it's getting to be a higher percentage of endovascular approaches than 10 years ago.
Yeah, that's for sure. That's for sure. So, for instance, what I can say, like, because of is the country where I'm working in the clinical part nowadays, here in France, more than half of the aneurysms are treated by endovascular. So, of course, because they developed the technique and they advanced a lot new devices, not only because of that, but also because of they got very good results for most of these, you know, aneurysm diseases. AVMs are different, and other diseases are different. So you have nuances of each department. But here it's true regarding the health system that they have a majority of endovascular approaches in the country.
Julio, you do aneurysms, Julio?
Yes, sometimes.
Sometimes.
Yes, as George said, depends a lot. If you work in a big service, sometimes there is, for example, in university, usually there is a neurosurgeon that work only with this. Do you understand what I mean?
Right.
Of course, if you study more a field, probably you do better. Do you understand?
Yes.
But sometimes when you live in a small city or a place that there is, because sometimes to operate an aneurysm, it's an emergency. So if you see, you have to do the surgery. And sometimes you can wait a little bit, so it depends, each case.
But you do have a vascular guy on staff at your hospital?
Yes, there is.
Okay. What are the other major vascular problems, George?
Yes.
Besides aneurysm, you have AV.
You have nowadays. Nowadays that's the point. So neurosurgeons in general sense, they are getting involved in this kind of endovascular procedures, even there in the States and in Brazil and throughout the world. So we are actually treating strokes, and you know, another problems are AVMs and more rarely dural fistulas. So I think I would say that nowadays the second point in endovascular diseases are especially stroke. So stroke is a kind of pretty frequent disease, and in these first world countries, likewise here in France, so they have special programs for the patients. So we have calls, and then we just go there and we treat these patients that used to have major neurological deficits after stroke, and nowadays they are getting the opportunity to improve and to recover for a cerebral stroke by using the endovascular techniques. You also have mostly chemical technique, like drugs that the neurologist can apply. But if you have a major vessel compromised, so you have to go there and take it out, the obstruction.
Right. So mostly embolic strokes that you work on with that, right?
Yeah, we use embolic for the most common stroke, and also for the hemorrhagic stroke, which is caused by aneurysms.
Okay. Okay. So there's no rebleed.
No rebleed, no rebleed.
Okay.
So you go there is a different way, as I mentioned, because when we go surgery, we go and mechanically we exclude the lesion from the circulation. And when we go endovascular, we stimulate thrombosis inside this bubbles inside the vessel. So it's a different philosophy, but similar goals.
Very good.
Yeah.
Do you guys have any questions out there?
George,
I have a question.
Go ahead, Simon.
Oh, thank you. Thank you so much, Dr. Mendes. A very, very interesting presentation. I'm in Tokyo, Japan here, and I have a weekly meeting with an interventional radiologist who is very involved, of course, with the diagnosing of brain aneurysms, and she often is involved in surgeries to remove aneurysms, but I don't know the extent to her work. But I'm wondering, have you ever met a representative of Japan, a Japanese neurosurgeon, and are you aware of?
Go ahead. I have a couple of friends there in Nagoya.
Oh,
Yes.
really? Wow.
Yes, yes.
And are they doing the same type of subspecialty, the same type of surgeries?
Yeah, definitely. Japan is actually a pretty nice country for this kind of procedures. But they are mostly open surgical people and traditional ones. Likewise, my country is also a traditional neurosurgical country. But they are developing a lot endovascular procedures. That's for sure. That's for sure. And they work a lot in research, and of course they are fast growing. Yes. Definitely.
What other countries? What other countries are doing a lot of endovascular besides France?
States.
The United States.
Definitely, yes.
Okay.
You have States and Germany. Germany, it's a good country either, and you have centers in Turkey and Europe in the general sense, because Europe is a bit different. I'll talk about France, but mostly the health systems here are similar. So you have kind of public system for everybody, and then specific programs. So you have this kind of specialty here, which is this interventional neuroradiology. So mostly you can come by different fields, including neurosurgery and neurology, radiology, and then you can dedicate yourself only to for doing it. So it means that you're gonna work your life only with endovascular procedures. Mm-hmm. So that's mostly the rule here in Europe in the general sense. In States, in Brazil, you can work by doing both. So it means that if you think that an open surgery is the best choice for your patient, you go ahead and you do the surgery. If you think that this embolization is the best option, you go ahead and you embolize the aneurysm. Or the procedure.
Would you say that that neurosurgeons, especially the ones that specialize in endovascular work, are being more aggressive now than before and trying to get the lesions early because of their success rate? Probably,
yes. I would say that we are moving towards that. Yes, because as long as you're increasing safety with minimal invasive techniques, probably you have this kind of management. Probably.
Okay. And what's your impression of neuroimaging? Is it getting that much better in your eyes? Since you started training 7 years ago, you said, right?
Yeah, 9 years ago.
Oh, 9 years ago. Would you say it's gotten appreciably better, or just a little better?
Definitely.
A lot better?
A lot better. Not a lot better. Not only imaging, but also imaging. Devices. So you have, earlier diagnosis and faster diagnosis and then you can treat even faster your patients either. That's the case of stroke. So, for instance, here in France, so that they have a really, really robust health system. If a patient has a stroke here in this country, you know, the patient will have an ambulance to take him into the hospital in about 15 minutes maximum. And then this patient will go straight to the MRI. And the patient will have a neurologist, an interventional neuroradiologist, and a regular physician, an intensive care physician with him. And after the diagnosis, the MRI here takes about 15 minutes more. The patient will be treated with, you know, thrombolysis with venous drugs immediately in the MRI. So it saves you a lot of time. It saves you a lot of time, and time's brain. So when this patient has, like, for instance, a diagnosis of major vessel occlusion, then we are ready to go, see what I'm saying? So the patient just go to the angio suite, and then we take out the clot, and the overall timing, it would be maybe 45 minutes or even less. So it's kind of, but the thing is, because they have this kind of, you know, health system, which is public, and everybody has access. So if the patient, you know, lives in the countryside, so then they have the helicopters and this kind of approach, which is not the same reality back home in Brazil. Probably you have this reality there in the States. So that's it's mostly linked to the health system, but outcomes are completely associated with time in these cases.
Well, do you know, is it similar? I'm kind of curious. Is it similar in the States that they give thrombolytics so quickly as they do in France?
Yeah.
It is. So they give it very quickly.
You do have in the States multiple. I'm not naming, but multiple departments that they do it.
So the ambulance. I've seen pictures of ambulances. There's one ambulance in Germany that has an MRI on the ambulance. When they suspect a stroke, they send the stroke ambulance.
Yeah.
Do you have that in France too?
Yeah. Not here in my city, which is Limoges.
Okay.
And but mostly throughout the country. So in Europe, France and Germany, they have pretty similar resources. Definitely. So what happens here in France is that as long as somebody calls, what they call here SAMU, as the health emergency system, then this system just call us and just saying that there is a patient who has a suspicion of stroke, and then you have to be ready to be in the hospital in 15 minutes. So then when the patient arrives in the hospital, the patient goes straight to the MRI in the suspicion of this, and then the neurologist will do the examination mostly in the MRI. So it takes very few minutes to have the diagnosis and then to go to the procedure. It's a reality here in this country, but as I mentioned before, it depends on the city and depends mostly on the system, because in these cases, time is exactly that's a phrase that a sentence that we have this in interventional neuroradiology. Time is brain, so you have to save time. You have to save time.
Well, you know, I can, and you guys might appreciate this. As an emergency physician, it was kind of tough when they had thrombolytics on trial for strokes. As an emergency physician, we had to talk to the patient's family, and of course, you have to outline the ill effects of the drug if it didn't work, which was death. It was really tough to get people to sign to be a test patient for a thrombolytic. But I guess it's past that stage now. It's kind of an accepted therapy, right? It's accepted, George, now. It's pretty well, it's standard care.
Yeah, right now here in it's no doubt about that. So to do thrombolysis, I don't know exactly nowadays the reality, the current situation back in States.
Yeah.
When I don't think that it's a big deal. Huh? I think it's okay, but it's pretty well established that you have to provide treatment, yes, and of course the patient is admitted by a neurologist who would decide actually for this thrombolysis. Here in France, usually we discuss together, and as long as the patient has a big thrombus, which means that a major vessel is involved, usually the patient goes thrombectomy, which means that we go through the groin towards the neck vessels, the neck artery, the carotid artery, and then we'll go with, you have different techniques, huh? So you go there and you can aspirate the thrombus, or you can release a stent, which is a retriever stent, and then bring it back to thrombus. So and these treatments are pretty successful actually. The problem nowadays is that we don't have yet a clinical trial that proves and establishes that thrombectomy is better than thrombolysis. See what I'm saying?
Right.
So it mostly depends on the institutional policies, and that's the reason that I think that for the following years, not that much. Soonly we'll have good clinical trials, mostly European trials that will show it up, and I guess that probably thrombectomy will replace thrombolysis in this kind of major vessel thrombus. That's my opinion.
That brings up another question. Are you involved with catheterization to remove acute thrombi?
Yeah, definitely. Yeah.
How quickly do they call you to say, Doc, we have someone with a thrombus, can you come down to the cath lab? I mean, does that happen? Does that happen pretty fast?
Yeah, definitely. So you have 15 minutes to be there, and you have mostly 15 minutes to take out the clot.
Really? No way. That fast?
Yeah. So it's the thing that you have to puncture and then go fast, and then arrive there. It's a pretty simple technique actually. So most of the time, so you go there with the catheter, and then you can use both techniques. You have a kind of suction catheter that you go there inside the vessel, for instance, MCA, and then you have a pump that will aspirate it. You connect the pump, and then you release the obstruction. And if doesn't work, or if yourself you prefer to use a straight retriever, so then you go inside the artery, inside the clot, and then you open up a stent, and then the stent will retrieve the clot. See what I'm saying? So it must be fast, because in this case, it's not exactly the technique that you are using, but the timing that you can release the clot.
Well, that's a pretty miraculous occasion. I know in the emergency room when thrombolytics were first being used, and you had a patient that probably was having an embolic heart attack. When you gave the thrombolytics, sometime it was quite dramatic on the patient just going, oh, the pain is going away. And you could see it in front of your eye. Now, I mean, of course, not every case, but it would happen occasionally where you wouldn't give morphine, or you couldn't attribute it to being caused by any other therapy that you were giving, but you'd give the thrombolytic and they would just slowly get better. It was like you could see the clot dissolve in front of your eyes. It was quite dramatic. Do you get that kind of result?
Of course, yes. Yeah, I do agree with that, and for neuro either. But as I mentioned to you, it depends on the size of the clot. So if the clot is a huge clot that we are seeing, for instance, we use here MRI, and we have a special protocol that the MRI is done in between 10 and 15 minutes. So if we see like a major vessel occlusion, it means that we have a carotid occlusion or a basilar trunk occlusion or an MCL occlusion. So then you go there and just release the stent. It's the best way to to release to retrieve the clot and to provide flow to that patient, avoiding major neurological complications. Mm-hmm. So if you have a distal clot, a thin clot that can be treated like by using thrombolysis. For instance, M3 and 4, so pre-distal clots, it's a very nice treatment. It's and it works very well. Mm-hmm. But for huge and major clots that you have a 4 millimeters clot or a 3 millimeters clot, I would advise to open up a stent and retrieve it.
Okay, George. Anybody else have any questions? Simon, Julio, Diego, Dustin?
George, can you tell me more about the unruptured aneurysm? Because as you said, the image now is better than a few years ago. So now we can discover a very, very small aneurysm. And sometimes it's a big problem for us as neurosurgeon. How can you manage this in your city in Limoges? In your service?
Yeah. So as I mentioned, Julio, it's a question of expertise of your department, and it depends mostly on the department. Myself, I'll have my particular way to deal with this, because I'll still operate some of my patients, and then I'll treat some of patients with endovascular. But it's mostly well established that aneurysms over 7 millimeters, asymptomatic, should be treated in patients in a good age. It means that under 60, or it depends on the routine activity of the patient. But the 7 millimeters is a number established for a couple of studies that have been published. And it depends mostly on the patient's history. So if the patient has a history of aneurysm bleeding before, so it means that you should keep on mind it, or multiple aneurysms either. So a patient who has multiple aneurysms and familiar history of bleeding, they should be mostly treated, but it must fit for every single case, as I mentioned before. But the general rules would be this: would be the size, the age, and the familiar history.
Okay, very good, George. I really appreciate you coming out and spending the time. It's pretty late. I guess it's not late for a neurosurgeon. You guys don't sleep, right?
Very few hours.
One more question. Was Julio a pretty tough senior resident?
No, he was spectacular. It's a great friend. It was a pretty nice time when I was there in Belo Horizonte.
Okay, good. Okay. Well, okay, everybody. We'll go off camera, but I will just say good night to the audience. And again, George, thank you very much for coming out. You're always welcome to come back for another presentation.
Yeah.
Okay, I'm just going to say good night. Hold on, George.